As said, if you have questions, please raise your hand and something soft will be thrown at you. So, Patricia, thank you so much for this inspiring and also somewhat moving story, because I think it resonates with a lot of healthcare professionals, nurses, and it struck me that in the movie we saw about the week, there was a colleague who said that her worry was that nurses would lose their clinical reasoning, while your study actually shows the reasoning is still there, the feeling is still there, and this doesn't take that away, it strengthens it. How important is that?
It really is important, and I think one of the strengths of Concern is that we worked with nurses to develop. Any nurse who in this audience knows that they've had a patient like I had, where they knew something was wrong, and they either communicated it or they didn't, and they either saved that patient or they didn't. But I think this is a good example of a tool that amplifies that feeling that we have, that clinical judgment, and it makes it stronger. It gives us additional evidence so that we can act on it and that our team members have access to it so that we can work together to save our patients.
And it seems so obvious to have user-centered design, but just a show of hands, because I can see you a little bit. Please raise your hand if you've at any point during your career had something present to you as this is a solution for you, and when you thought you have no idea how my work is done. So, als je ooit hebt gehad dat iemand zei, dit is echt iets heel fijns voor jou, en dat je dacht, dat werkt totaal niet voor mij, je hebt geen idee hoe ik mijn werk moet doen, laat dan even je hand zien. Oh, it's still okay. No, I thought everybody would raise their hand, but it's okay.
Me too, I'm surprised. If we were in the US, everyone would raise their hand.
So then the user-centered design, I mean, that must take a lot of time as well, right? I mean, instead of thinking about a perfect solution by yourself and then just designing it, you have to talk to people, really understand their needs. Why is it worth it?
Yeah, it takes years to do. So this project was funded by a grant from the National Institutes of Health, and we did take the time that we needed to incorporate user-centered design in different phases. So first, when we were developing the predictive model, you have to develop the cut scores. So that was the first place where we had user-centered design around. You can calculate what the cut scores are mathematically, but you have to work with clinicians to identify the right cut points so that you don't have over-alerting or under-alerting. So that was one place. And then we took about 2 years to develop the user interface and the app that comes up if you click on the patient list. And again, that took sessions with clinicians, simulation, seeing how they were doing their work already. As I mentioned in my talk, the doctors, the nurses, they were adamant that they didn't want to pop up. All of you who work in the medical center here use Epic. We have Epic in our hospital, and there's something called a best practice alert, a BPA, and that's usually the approach that's used for clinical decision support. But the clinicians told us, no, don't do that, because we just turn those off. We want you to develop something that will be easy for us to use in our existing workflows. And they identified the patient list as the place where they typically refer when they're doing their patient handoff, when they're doing rounds, when they have their huddles. And so they thought if we put the information about the patient's concern score in the list, that would be a place where they could access it and that they would use it. And you can see from the results of our clinical trial that it worked.
But it takes you time as a researcher, but it also takes their time. How do you persuade them to co-create with you?
We give incentives. I guess
also financial?
Yeah, we do. We do give gift certificates to nurses and physicians. But I encourage all the nurses in this audience to participate. So if you have the opportunity, participate, because it's really important as we integrate AI into healthcare that nurses understand, first of all, have a say in how this AI, what what we automate, and then how the AI is integrated, because then it'll be a lot easier to use, and a lot more functional. So we do provide incentives because nurses, physicians are very busy, so it gives them a little extra incentive to say, yeah, okay, I'll take part in that work.
Yeah. And then this way of working, user-centered co-creation, is that something that is being widespread adopted now in research, or is it still special if you do it this way?
Yeah, I would say in the US it's pretty widespread. I think there's a recognition that it really doesn't work to create something and then just hand it to the end user. I've been working in research with clinical decision support for over 20 years, and I remember early on that it was very common just to create decision support and stick it into the electronic health record, and sure enough, it's a negative trial, and when you go back and you look at the number of clicks and you look at how many times it was accessed, it's a very small percentage of patients who actually got the intervention.
Yeah.
And so I think we've learned from that we do, if we want people to use it, they have to have a say, and we really have to listen to end users about, what are the pain points they're having, how can we address this, what is their workflow. They're not going to develop a new workflow for this particular intervention, so how do we integrate it into what they're already doing, and to make sure it's useful and it's used.
I always think about the disbalance between putting effort in and getting value out. So you can turn both knobs, so to say, take the effort down, so incorporate it into the workflow, and then make sure that it has added value also from the perspective of the user. Demonstrate it where it needs to be used, and if it doesn't have value there, sorry, it just doesn't work. But in this case, it worked.
Well, I think that's a really good example. I think it's very important to have champions when you're introducing a new innovation. And for all the projects that I do, and certainly for the Concern project, we had nurse champions on all of the clinical units. And what they did is talk about what those workflows were on their unit where they could use it, and it would be a no-brainer. Yeah. And without that, without those champions coming up with those workflows where it's going to be integrated, it won't be used, because nurses are very busy, and so you really have to sort of make sure that you think very carefully about that it makes sense to them, and then they can adopt it, and they'll get used to this new tool, especially if it's useful.
It also makes me think about this quote, and it's either from Peter Drucker or from Abraham Lincoln, but if you co-create in such a process as a nurse, right, sometimes you can say, well, oh, this future of AI is coming towards me, but if you co-create it, the quote goes like, the best way to predict the future is to create it, right? So if you have certain ideas about how the future of your profession should look like, go make it.
Right. I agree with that. And I think there's plenty of nurses here who have ideas about how AI could improve their practice or patient care.
Are there any questions or comments or suggestions? In the back, all the way in the back. I see one hand. And he's not daring to throw all the way that to the back.
It's hard to see.
But thank you for bringing the catch box.
Thank you. Do you have any ideas whether a concern or a similar program is available for healthcare at home or patient with chronic diseases, or like, for instance, in the outpatient clinic environment?
Yeah, that's a great question. So we have developed it for inpatient acute care and critical care. We do have a new grant to expand it to pediatrics, and in the pediatric environment, we are adding the patient's parent's voice, because we think that the parents probably know if their child is not right, and we think that should be part of this tool. We have not looked at any of the outpatient clinics or environments yet, but I would imagine that this type of tool could be useful there too, but we haven't done that work to be able to expand it there.
Thank you for the question. I'm going to look around again. If not, I'm going to ask a question, of course.
there's
Oh,
one,
there's in the
yeah.
middle, yeah, and someone in the front. You are allowed to throw. There is medical assistance available.
That's something I've never seen in the United States. I've spoken at a lot of conferences.
The
I've
catch
never
box is
seen
new
it.
to
No,
you.
I
So
haven't seen
this
that.
is innovation happening right here for Particia.
Many thanks for your personal story to share it with us. And I'm also very interested in one or part of your story, and that's also what you told was the understaffed hospitals, and that maybe Concern can assist in that way. But I'm very curious how that will work in the practice, because I'm also a nurse, and I know also nurses will be very connected to each other during the work. And to replace them for something like Concern, because it's needed, because the hospital is understaffed, I'm very curious how we can reassure them that they can provide a very safe care, because I know that people or nurses are mostly saying van, I need my colleagues to provide the best care, and when we are understaffed, there is a big problem. That's also the problem I see on my ward.
Yeah, thank you for raising that. So I did not in any way mean that it would be okay to understaff and then have concern. And I think the reality is there are hospitals today that are understaffed and they don't have concern. I would say that we need to have good staffing in our hospitals, and patients in well-staffed hospitals are better off with concern. I think patients in understaffed hospitals are better off with concern, but I would agree that we need to have good staffing first to save patients.
So maybe to add to that, I know of examples in elderly care in the Netherlands where you have a sort of virtual colleague, which you can ask questions about, well, all the knowledge that's available in your protocols and guidelines and so on and so forth. And that saves a little bit of time instead of asking the senior colleague and so on and so forth. But of course, what she said, I agree with that.
Well, so the other place where, so in the US, there are some rural hospitals that don't have intensivists, so physicians and expert nurses who do intensive care, and they do use technology to where the intensivists and expert nurses in the academic medical center can actually do rounds with the rural physicians so that they can provide recommendations, but it's really the rural, so they don't have these staff anyway, and this actually augments what they're able to provide in those settings.
Yeah, so by no means we mean cut down on staff and replace it with technology, by no means. There was a question up in the front here. Do we have another catch box available? Or should I just walk to? No, yeah, just if he throws it to your left, he can catch it, and then you can throw it to the front. Ah, I love this.
Wow, this
Wow.
is great.
We've been practicing all morning.
How does it work? Oh, there it goes. If there is there a ceiling to what AI can do? And if there is no ceiling, won't it at some point replace our judgment or get better than the nurse's judgment?
Well, I guess that's the question. So will AI become super intelligent? My perspective is that we will always need humans to have, for nurses, we always need clinical judgment, and that's something that can't be trained or can't be programmed into a computer. I guess I'll ask my physics AI colleague what he thinks about that.
Oh, yeah, it's a very important question, and I would just like to paraphrase Yuval Harari. He's a famous Israeli historian who's writing a lot about technology and AI, and he foresees a future. He doesn't say it's going to happen. He foresees a future of more intelligent computer systems like AI, and he also foresees that that's going to change the way we do jobs and also value jobs. And one scenario he sketches is the scenario where the income difference between doctors and nurses go the other way around. Because what's actually left is that the human touch, right? I thought this would be a standing ovation, but never mind. It is, as I say, the best way to predict the future is to create it.
You're lucky that there's more nurses here than doctors.
So this is a very important part, right? And I personally also agree with the viewpoint that it's the inter-human relationships that's very important. I like to paraphrase John Lennon. John Lennon, he had a song back in the days where he sang, "Life is what happens to you while you're busy making other plans." Well, for me, healthcare is what happens to you while you're busy making treatment plans, right? So it's everything interconnected in relation in between it. More questions? Yes. I thought we had 2 catch boxes. Oh, yeah. Judith, can you try? Via. Somewhere over there. Oh, yeah. First here, then we go there. Yeah.
Okay, hello, werkt dit? Yeah, okay. So I really like that the system, it triggers on the documentation of nurses. But if I look forward, like to implementing this in home care or in more private places where nurses are, I'm wondering in what way would it support unwanted diagnosis for people who live at home. For example, people who have dementia who don't really want to get diagnosed. Would a system like this being implemented in different environments support unwanted diagnosis for people? And would it be a good or a bad thing?
To understand it, do you mean could it possibly lower the threshold to get treated? And would that be unwanted?
Nou, even in Nederlands denk ik dat waar ik me zorgen om zou kunnen maken is dat als je zoveel informatie verzamelt op het moment, als je bij mensen bijvoorbeeld thuis komt. Ik ben zelf wijkverpleegkundige, dus en je verzamelt al die informatie en met AI kan je toch al snel voorspellen welke symptomen bij bepaalde ziektebeelden passen. En ik vind bijvoorbeeld specifiek met dementie, dan zie je dat heel veel mensen niet gediagnosticeerd daarmee willen worden. Dus hoe zie je dan voor je dat? Ik vraag me af of dat een goed, hoe zeg je dit?
Of het gewenst is dat we dat doen?
Of het gewenst is om dat daar te implementeren. En of daar waar de goed en fout hierin ligt om dat daar te gaan gebruiken. En succes met dat vertalen.
He says good luck translating that. Don't shoot me, but I think the question is related to, could you foresee situations where collecting information about a patient or a client and then analyzing it with AI and then predicting something and diagnosing something is unwanted? Could there be ethical trade-offs between using the data and applying knowledge?
No, absolutely. I mean, that's one of the questions we have, right? And that's why we have to be very careful when we're caretakers of people's data, that we don't use them in ways that they haven't approved, right? It's an ethical. So, for example, we have that now with genetics, right? Where there's certain genetic disorders. If insurance companies in U.S. knew about these genetic diseases, they wouldn't provide long-term care insurance, for example, to people who have a genetic disposition to dementia or Alzheimer's. So I think that's more of an AI issue than a concern issue, right? And a data governance issue. In terms of home care, there is a study right now looking at a version of concern in home care, and it relies more, when you think about the documentation patterns in home care, they're less frequent, right? Because they're done by when the nurse comes in to check the patient. And so that version of the model relies more on the natural language processing and now, more often the large language models to identify like diagnoses and symptoms. And yeah, identifying those which otherwise might not have been identified if the data isn't safeguarded could lead to unintended consequences.
Yeah. I also saw a raised hand there. Yeah. So maybe you can try to throw it. Yeah, it's easy. Yeah, perfect.
I was wondering what the nurses do when there is a high concern score, but your gut feeling is telling you, well, there's nothing wrong. Like, do you listen to your gut feeling, or maybe you're going to do unnecessary diagnostics and the costs are increasing? So I was just wondering, what do they do in these kind of scenarios?
Sure. So concern is different than other early warning systems. So for example, I heard this week from some of the nurses, they've used the MUSE, the Modified Early Warning System, and there's generally a protocol around it. So if somebody has a high MUSE score, you would call a rapid response. So concern, what we teach nurses, if a patient turns yellow, you should be asking yourself, is there something going on? And you should use your clinical judgment. We don't have a specific action that you need to do because a nurse it's supposed to support clinical judgment, not tell you what to do, right? It doesn't tell you what the next step is. So for example, if you have a patient who just came back from a procedure and you're required to document more frequently on that patient, you're monitoring them more frequently, they probably will change color, right? And when you say to yourself, oh, this person changed yellow, oh, but it makes perfect sense because I'm doing a lot of vital signs, or I'm giving blood, and so I'm doing vital signs every 15 minutes, so it makes sense that it is yellow. It's really supposed to trigger a conversation if you're not doing something that you know is triggering the vital sign, more frequent documentation, to try to take a step back and say, is there something going on with this patient? But there isn't an automatic intervention that you would do. It's supposed to support clinical judgment.
But is there also then a question of accountability here? So let's say now you're fully responsible for the care you provide. Now AI comes in, and now it's your judgment to trust the AI or not.
I think there's accountability with any AI system, and so I think it's really important for nurses I think we have a responsibility to understand what these systems are that are integrated into our electronic health records, right, that we're using. We need to understand what are the data sets that they were developed on, so that will tell you what kind of bias might be there. And when these systems make recommendations, it's up to us to actually do the next step or not, right? We have to decide what the next step is and whether we need to do it. And there is accountability, and that falls on us because we're the clinician with the patient. We always should be able to explain our decision to either follow the recommendation or not. We should be able to explain that to the patient and also to our care team. So we should never be using these systems blindly because, that's the strength that humans and nurses bring to the table, our clinical judgment. And so we can look at that pattern and see what the AI is predicting, but it's our decision and we're accountable for the decisions we make.
And how can this audience and all other nurses become more knowledgeable about AI and knowledgeable enough to make these kinds of judgments?
I think it's asking the right question. So when you're told that there's a new sepsis alerting system being introduced into your electronic health record, and I think it's important to ask the right questions about that system, right? So how was this developed? And understand how you're supposed to use it and what your accountability is. And so all of that should be part of the implementation. So I think that nurses should be involved in selecting the systems that they're going to be using, and then when they are selected, in implementing them. You know, there was a paper recently in one of the JAMA journals which talked about a sepsis model that was developed by Epic. And so you have Epic too. I don't know if you implemented their sepsis model, but it was developed by Epic a couple years ago. Epic talked about its development. They presented some very impressive data on the accuracy, and they recommended that their customers adopt it across the United States, and many hospitals did adopt it. The experience of the nurses and the physicians taking care of the patients was, wow, this seems to alert a lot, and it doesn't seem that accurate. And then a group from University of Michigan actually did a study, and what they found was that 64% of the time, the Epic sepsis index did not identify patients who had sepsis, and it only identified 7% of the patients who actually had sepsis that weren't already identified by a clinician. And so when Epic was asked about this, they never really were upfront about, they said data, they used data from their customers. They didn't say which customers, what the demographic or the racial ethnic characteristics were of those customers. So they still haven't made any of that clear. And I think what is, I think the main lesson that I took out from that was that, you know, in all of these hospitals that embraced this model and implemented it, nobody asked the questions first, right? What data was used to develop the model? Will this even generalize to our population? Does it need to be adjusted for our patients before we turn it on? So it was just turned on in the EHR. So that should never happen. And I think the first step for nurses is to become more knowledgeable about the systems that are being selected. You should be part of that process, and you should just be asking these very basic questions. You do not need to understand the math behind the system. You know, very few of us will become AI experts, but everyone needs to be AI literate, and every nurse needs to be AI literate.
Thank you. More questions? I see a hand up front here. All the way upstairs, boven, ja. Even kijken waar. Ja, daar. Ja, je hebt hem al. Top.
Okay, hello. I'm start to try in English, but maybe later I'll switch. Thank you, Particia, for your personal story. It touched me as a nurse. I'm working as a nurse more than 40 years, and I recognize it. In our hospital, we implemented, I think 9 years ago, the NEWS, the National Early Warning Score. And till now, we have the problem that nurses, not all the nurses, of course, but there are always nurses, they don't dare to call their own doctor. Or they don't dare to call the SIT system, the system that comes if there is a high score. It's quite simple. If there is a score of 7 or higher, then they have to call the SIT system. What's in English? The rapid responsive team. But often they don't do that first, but first they call their own doctor. While the appointment in the protocol is just to call first the rapid responsive team to prevent that there is a discussion between the nurse and the doctor of the ward, to call that team. I wonder if there are nurses here who recognize this, and I wonder, or Particia, or you recognize this, and how you did. Do you have a problem to solve that? Because AI will not help in this.
Mm-hmm.
This
I
is
hope
about
I'm
changing
clear.
behavior, yeah.
Yes, yeah. And you know, last year I was interviewed by the Wall Street Journal. They interviewed nurses from across the US who had experience with AI, and most of them had very negative experiences, and this was a common comment that nurses made, that they were required to do actions they didn't agree with, and they felt that that wasn't right. And so, you know, when I hear about, you know, first of all, I think nurses probably should have been involved in implementing the news, and they probably weren't. They should have been involved in determining what the cut scores were. And these kinds of situations or cases need to be studied up front, right? So, because I know that it's very common, even in our hospital, they use the Muse, and they do have to call a rapid response if it's above a certain level, but they did involve nurses in identifying, you know, with the physicians and the intensive team on defining what that cut level was, and then they have regular meetings around how well it's working, and they're refining. So it's really that participatory design that, you know, I talked about it with concern, you know, how we develop that in a research project, but you really need to use that approach anytime you're rolling out AI, and that you need to, anyone who's going to be involved in using the AI, they need to be part of that rollout plan.
Yeah. So we're running out of time, because my most important task is to get you to the ball in time. But we can have one final question up front here.
Please, can I say one thing more?
Oh ja, roep even snel, ja.
Ja, dan heel even in het Nederlands.
Ja.
Waar het mij om gaat, het is niet helemaal overgekomen denk ik, is dat verpleegkundigen lang niet altijd het zitteam durven te bellen en dan eerst hun eigen arts bellen. Hè, de zaalarts. Hè, het gaat vooral in de weekend, avond, nachturen. En dan zeggen ze, als ik het nabespreek, wil mijn arts niet passeren.
Yeah, so it's about...
Het is cultuur.
It's about, it's culture, it's behavior, so it's about the point, the main point she wanted to make was, the protocol says, call the rapid response team, and they're scared to go over their, let's say, ward doctor.
Oh, okay. Okay.
So how do you address that?
And that's not an AI issue, right?
No.
I mean, it's clear that the health system values nursing. When I look at this beautiful, you know, celebration of nurses, it's clear that your health system values nurses, but I think that that is a sign that there needs to be some more work on the teams and nurses and physicians being part of the same team and being able to work together.
Yeah.
Well, thank you for your presentation.
Fine,
on task-specific AI, actually, how your data can help decision making. I was interested on generative AI, which can create new things, which can create hallucinations. How do you think that can help nurses in our work? And what do you see as pitfalls or challenges? Could you give examples about task-specific AI and machine learning, which is different from the generative AI, the large language models?
Yeah, so I think that one of the places where AI could really help nurses is nursing documentation. So right now, nurses are burdened by the amount of documentation they need to do. A lot of it could be done using generative AI. And you're right, it does hallucinate, so nurses do need to check the notes before they save them in the patient record. But I think that, you know, with documentation burden as such a big problem, I think it's worth our time. Of course, it does change a little bit the way we practice. So traditionally, you know, we do our assessment and we might talk about the assessment with the patient, but most of it we just write down. If you're going to use AI to write your notes, that means you have to talk as you're doing your assessment so that the system can pick that up. So it changes the way we do our work. We need to practice, and sometimes it will hallucinate. And so, but the way we improve that is we give feedback, right? And we participate in programs where they're piloting these types of AI programs so that we can make them better.
Thank you. I agree with you on that. Thank you.
Als wij, doet hij het nog? Ja. Als we AI willen toepassen in ons werk, wat moeten we morgen anders doen?
What should they change tomorrow if they want to apply AI in their work?
I would start with the documentation. I think that is, documentation burden is a major cause of nurse burnout, and it's a major use of nursing time. So I heard I heard people concerned about staffing, right? So if you were spending less time doing your clinical documentation, you would have more time for your patients.
Thank you.
So we're running a bit late, but I don't care because we had a true connection with each other. So thank you for that. Thank you for asking the questions, and please give a warm thank you to Particia Dykes.
Thank you.